Hi, everybody. I'm Dr. Tapan Koticha. I'm a periodontist practicing in Edmond, Oklahoma. Today, I'm going to talk to you and share with you my insights about 3D microscope enhanced periodontics and implant dentistry. Just a quick primer on what a 3D microscope is, because it's a relatively new technology. Here on the screen, you'll see on the left image is me using a conventional surgical operating microscope, and on the right is me using a 3D surgical microscope. A couple of key similarities. The technology from the microscope is the same. The objective remains the same. It's the same kind of optics, and the guts of how that optical image is processed is still the same. The difference lies in that the conventional surgical microscope has an eyepiece, as I like to call a tube that you need to look down through to see your image as you're working. In contrast to that, a 3D microscope has an image portrayed on a 3D screen, and you're usually using 3D glasses to view your image. And I will later on in my little chat talk about how that has made a huge impact on my practice. But a little bit of why do we use microscopy in perio? How is it making a difference? And I'm going to use a couple of my cases to make the point. A quick run through this young lady came in with a failing number 10. There's some external root resorption and internal root resorption. The solution was for us to do extraction and immediate placement, but we are also dealing with some soft tissue dehiscence and a very thin and inflamed biotype. We proceeded to do an immediate implant placement with some immediate professionalization and hard tissue augmentation, but we also did a soft tissue augmentation to try and modify the biotype or the phenotype here. And this is the outcome at the end of 3 months. This is what I would call a conventional or macrosurgical technique that we used for this patient. This is right before the final restoration. This is how we sent the patient to the restoring dentist. But you can see while we maintained the papillae, we've actually improved the soft tissue profile. We've gotten a nice knife edge margin on that implant temp, but still the pink aesthetics leaves a lot to be desired. You can see a couple of different views of the same thing. And now I'm going to transition to this other case that we used a similar approach, but utilizing microsurgical techniques. Similar situation, external root resorption along with some carious lesion on the lingual aspect or the palatal aspect. The usual workup, similar approach. We did an immediate implant placement, immediate provisional, hard tissue and soft tissue augmentation. The only difference here was the technique. We used the microsurgical approach, and you can see here, this is on the day of the surgery, right after we finished. At 1 week, the healing is already looking very well. And this is the final restoration, the pictures I got from the restoring dentist. You can see again, we were again able to maintain the tissues, deal with the soft tissue, dehiscence and inflammation, get a nice knife edge margin and so on. But at the end of the day, a very well looking aesthetic result. And that in general has been my approach in moving more and more of my procedures towards using a microscope for them. Now, I'm going to go over a rundown of the quick benefits of using a microscope. And one of them is that even for my non-surgical therapy, when I'm treating perio disease, in this case, on the video, you see us treating a site with a furcation abscess, and you can see there I'm pointing out to the lesion there. But because I'm using a microscope, I'm able to use smaller instruments, very precise movements, and as a result, the degranulation happens with minimal trauma, and as a result, the healing is really good and really quick, which is sometimes very important in regeneration. As you can see, we're able to retrieve all the diseased tissue very easily. Another advantage, it sort of has broadened my scope a little bit. This is a situation where we were treating cement-induced periimplantitis, and as you can see, there's cement all over, and typically the only way for us to get this cement off well is for us to actually retrieve the crown so that we can thoroughly get all the cement off, treat the defect surgically, and then, if possible, even reuse the same crown. In this case, apart from all the overzealous cement that was used, the individual actually forgot to block the access hole in the abutment. And as a result, there was cement packing into the screw head itself. And typically in the past, when you're dealing with that, you either end up damaging the head of the screw, trying to retrieve that cement, or you end up having to remove the implant itself because you can't retrieve the crown. Because what we're seeing in the microscope, I can see very well, I can control my instrumentation very precisely. And as a result, we're able to actually retrieve all the cement with very minimal damage to the screw head. Obviously, we're going to change the screw head, but retrieval becomes a breeze with something like this. Another approach, and this is actually documented in the research, starting way back in the early 2000s with Burkhardt and Lang, this classic study where they actually did a split mouth design comparing conventional and microsurgical procedures for soft tissue coverage. And they used fluorescence angiograms to see how revascularization of the site occurs. And that's, we know from our healing studies that that's actually one of the most key factors in regeneration. Early revascularization helps a great deal. And as you can see on these images, the top is the macrosurgical procedure and the bottom is the microsurgical procedure. Between the day of the surgery and the first week, you can see the significant amount of revascularization that has already occurred when you're using a microsurgical principle. And you can see that on the data as well. Much better recession coverage, much better long-term results as well. And I think that's what I've found in my practice as well. As you can see here, this is a case I treated with a microsurgical approach. It's actually a free gingival graft because we were dealing with a very complex soft tissue defect. But at 1 week, we're already seeing significant revascularization of the free gingival graft. At 2 weeks, it's significantly blending in, healing really well. And as a result, we tend to get much better results, much better regeneration of tissues, and to top it off, very good patient compliance as well. Here's another study that's, again, the same thing, looking at different techniques for root coverage, comparing macro and microsurgical procedures, and the same thing, mean root coverage is improved when you're using a microsurgical approach. Complete incidence of complete root coverage is also improved significantly. And again, it's been my experience as well. This is a situation where a tooth was moving out of its alveolar housing because of orthodontic treatment and started developing some pretty significant gingival recession. And the way we treated this was with a laterally moved pedicle graft combined with a soft tissue graft from the palate. And as you can see, again, using the microsurgical approach allows me to use much finer sutures, much more tension-free closure, very minimal trauma throughout the whole process. And as a result, the same team, we're getting really good results. The image on the left is a healing photograph at just 1 week. At 2 weeks, you're already seeing significant regeneration of the tissues. And then at 3 months, we're getting a significant gain of keratinized tissue, significant gain of attached tissue, and obviously complete root coverage. And this has been, again, something that, yes, it's achievable with macrosurgical approaches, but the healing period takes much longer. There's a lot less predictability with it, and it's a much more difficult healing period for the patient. Again, another study just to bolster and reinforce that same concept. Now, there's some disadvantages to using a conventional surgical operating microscope. One of the first things everybody who's ever looked into it is going to tell you there's a learning curve. You got to get used to looking down that tube. You got to get used to learning how to set up the microscope every time you use it. There's part focusing, making sure you're positioning it right. And that aspect of looking down the tube every time you move your eyes away from the objective to, say, look at a different aspect of the surgical site or pick up an instrument or anything, the moment your eyes move away and you go back to it, you got to readapt and readjust to the idea of that looking down the tube. And that is something that has been a significant learning curve when I first started incorporating microscopy into my surgical treatment. Now, the 3D microscope helps a great deal on this one. You can see on the video, you can see as I'm using it, I'm almost seamlessly moving my field of view from a naked eye perspective to the 3D screen and back without having to sort of spend any time readapting to that field of view, without having to move anything out of the way. And the significant, my posture is still very good, but it doesn't strain my neck muscles trying to maintain me steady in that one position. And so that has been a huge deal. Another disadvantage of a conventional operating microscope is that the patient positioning is key. You really need to be able to lay the patient very, very flat, very supine, and you need to be able to turn their face to a certain angle depending on which quadrant, which site you're working on, and which view you need for the surgical procedure. In contrast to that, if I'm using a 3D scope, as you can see on the video, I can actually adapt the microscope to fit the patient's posture. In my practice, I treat a lot of older patients, and a lot of times they're not going to be able to tolerate lying flat on their back for an extended period of time. And the fact that I'm not tied into those eyepieces of a conventional microscope means that I can move the objective to adapt to where the patient is positioned, but still be able to see the image straight in front of my face. And that, again, has been a huge game changer. Like I said, me being able to have that freedom gives me much better ergonomics and better adaptation to really difficult access scenarios that in the past I've chosen to move away from using a microscope because the access is going to be poor. Again, you can see how I can even bodily move to different areas around the patient from a 9 o'clock to a 10, 11, 1 position, and still be able to get that same magnified field of view without having to move the patient around with me or me having to move the microscope around with me. And again, that's been huge, as you can see in this video. So I can move around comfortably, don't have to adapt anything, just keep going with my surgical procedure. Another thing is your assistants. Whenever you're doing surgery, your assistant plays a key role in the success, and especially with microsurgery, your assistant needs to be in sync with your movements and what you're doing and what the procedure you're handling. So if you're using a conventional surgical microscope, you typically have to train them to also look down the tube, have an extra tube arm like what you see on the screen here, and they're looking down the same tube to see what you're seeing. Now, that takes a lot of learning curve for us, so it takes a lot of learning curve for them too. Now, again, with this, with a 3D microscope, that has again been a boon to my practice. As you can see, my assistant here is seeing the exact same image. She has all the same freedom as I do because she's wearing the same 3D glasses that I'm wearing, and she sees the same view. She can transition to a naked eye view, direct field of view versus the 3D screen as and when she needs to. And she doesn't have to go through this learning curve of learning to look down the tube. So those are all the benefits that I've seen. I think magnification and the use of greater and greater amounts of magnification has significantly improved my surgical outcomes, has significantly improved my surgical techniques. And as a result, my patients have benefited a lot. I wish you the best of luck in trying to incorporate more and more magnification in your surgical procedures. Trust me, I think it's worth it. Thank you.